Okay, so welcome everybody this afternoon to the ABC of CVD Prevention during COVID webinar series. This is the third one. We've reached the C of cholesterol. So I hope you're all in the right webinar. I'm looking forward to learning all about lipid management this afternoon. My name is Jonathan Griffiths. I'm a GP based in Cheshire. I'm also GP advisor for the Cheshire and Merseyside Health and Care Partnership. And if, like me, you've spent the last several months just thinking entirely about COVID, you're probably looking forward to spending an hour doing something other than that. Not that COVID doesn't remain important, of course, but when this pandemic finally does settle down, I think we're going to realise that we've got all the other chronic diseases that are still going to be there, still need to be dealt with. And many of them will have even greater challenges, having been in some ways neglected over the past several months. So it's important that we do remember these are the conditions and how we want to manage those. So in the next hour, we've got some great information coming your way about how we should be approaching cholesterol management and opportunity as well for Q&A. A couple of housekeeping things for you. So you're all muted, you're observing and watching, you can't unmute yourself and ask us questions. There's no chat function, but you should see that there's a Q&A function there, and we would very much encourage you to be asking questions to us. There's a 20-minute session after you've heard from our speakers where we'll be addressing those questions. So please do use that question and answer function. We'll pick those up and ask those questions later on. The session is being recorded, so you need to be aware of that as well. And obviously, because it's been recorded, if you want to come back and watch it again later, you can. And also, please do share to colleagues who might find this interesting. Our three speakers this afternoon, you can see them on screen. We've got Bruce Taylor. So Bruce is a retired GP and is the primary care CVD lead for the Strategic Clinical Network across Cheshire and Merseyside. He's going to be giving us a presentation about putting the C back into ABC and where we are now. So thank you, Bruce, and welcome for doing that session this afternoon. Suzanne Lynch works for South Sefton CCG and Southport and Formby CCGs. She's an independent pharmacist prescriber, but she's missing her time when she used to work in a lipid clinic for primary care. So has a wealth of experience about dealing with lipids, cholesterol in a primary care setting. I'm looking forward to hearing from her about how we should approach secondary prevention for cardiovascular disease with regard to cholesterol. And then finally, we have Scott Murray. So Scott is a consultant cardiologist at Wirral University Teaching Hospital, and so welcome Scott, and he's going to talk to us about lipids optimization and some new and emerging therapies as well. So we've got several people, well, lots of you are now joining the call, so we're going to crack on. So each of our presenters has been asked to do 10 minutes. I'm going to give them a warning at 10 minutes. And first up, we've got Bruce Taylor, putting the C back into ABC where we're now. Over to you, Bruce.
Thank you, Jonathan. Can I just check everyone can see my slides?
We can, thank you.
Great, okay. Good, so, okay, let's go back. So, welcome everyone. So, good afternoon, everyone, and thanks again for joining us for this third one, as Jonathan said, and thank you for the introduction. The ABC of CVD Prevention. This series was originally called the Anything But COVID series, but we did stick with the ABC series. So we're talking about cardiovascular disease, really, and I know this slide is probably very familiar to lots of folk on the call, but it's really important, I think, that when we come out of COVID, as Jonathan said, hopefully we will get out of COVID, we start looking again at the issues that really we need to keep focusing on. And CVD remains the largest cause of death in the UK. People die every 3 minutes, massive number of hospital admissions, and these in some cases are preventable causes of death, and it has massive impact on our health and social care. So we cannot forget about cardiovascular disease. I think we're all very conscious that practices in primary care are working their socks off at the moment on COVID, and that's absolutely right. But when we start to get past it, we need to go looking again at CVD. So we're looking then at the ABC approach, and these are the three major risk factors for CVD. And we've had two webinars I've been involved in on atrial fibrillation and a couple of weeks ago on blood pressure. And blood pressure is without doubt probably the most important risk factor, as I call it, the king of risk factors. But cholesterol, which is what we're going to talk about today, is also very important. This is a slide that you may have seen many times now, but I think it's always worth showing again. This is the slide that was developed by Public Health England in 2019, when they came up with their long-term plan to try and prevent 150,000 CVD-related deaths in the next 10 years by tackling these three major risk factors: AF, blood pressure, and cholesterol. And for cholesterol, they set some targets. It was really quite ambitious. And the first target was that 75% of people over the age of 40, between 40 and 74, were to have a CVD risk assessment, something like JBS3 or QRIS3. And 45% of those people identified as having a significant risk, 20% or above. And that, if you remember, is not quite what NICE has said, because NICE went to 10%. But for lipids, 20% 10-year risk, they should be treated with statins. And 25% of people with familial hypercholesterolemia should be diagnosed and treated. So they were the targets that were set for lipids. I think most people now overwhelmingly get the fact that having high cholesterol relates to heart disease. And there's been lots of studies now. Secondary prevention showed it quite, I think probably more importantly than primary prevention, that if you reduce LDL cholesterol, you make a significant difference to events. And they reckon that 25 to 28% of heart disease is related to elevated cholesterol. And as I say, after blood pressure, it's the most important. And if you can reduce LDL cholesterol by a small amount, you make a significant difference to vascular difference. So I think cholesterol does need to be taken a bit more seriously. I think it has been the slight Cinderella of the risk factors in recent years. And if you look at, if you like, where we are now in terms of detection rates, we're probably at about 49%. That's about 49% of people between 40 and 74 have had their cholesterol measured, where we should be getting up to 75%, and that's with a risk assessment. 35% who've had a risk assessment should be on cholesterol, should be on statins, and we want to try and get it to 45%. And here's the big kicker: FH, we've only got 5% that we know about. We want that up to 25%. 25% of people with familial hyperlipidemia is still quite a modest target, I would argue, but we're really nowhere near it at the moment. We're not at the races at the moment for that. Why are we struggling with cholesterol? Well, these are some of my thoughts why I think cholesterol has always been a bit of a challenge for us in primary care. And I think the problem is a lot of people have their cholesterol tested when they really don't need to have it done. I'm talking about low risk people, and people who are high risk often don't get it done. And similarly, you often find that in low risk people, they always wanted to get their cholesterol taken year after year after year, when it was the high risk people we need to look at. And then when we do get the risk, we don't often go on to do their Q risk to calculate whether or not that means something to that particular person. I think in primary prevention, I think there is variable support for behavioural changes, weight loss, dietary change. And I do think many people with very high Q risk scores do not receive statins. In secondary prevention, where the evidence I think is overwhelmingly better, we still have large numbers of people on no statins or suboptimal doses. And I know Suzanne's going to talk about this in a short while. And we don't have people having follow-up lipid testing and dose titration, bearing in mind that all the evidence, all the guidelines recommend a 40% reduction from your baseline LDL cholesterol. And we also now increasingly have people eligible for the newer agents, which Scott is going to talk about, and not really being considered for them. And I think we need to address that. With familial hyperlipidemia, 93% undiagnosed patients with possible FH are not referred. And I don't think it's fair. I don't think we have a very good regional or local service for that, and we really need to try and improve that. So there are significant pathways, really. I think there's other ones as well, and there's no doubt that the press and patients, I think sometimes within the medical community, we are slightly sceptical about statins, particularly I think for primary prevention. And there's been a very good paper that was produced in the BMJ in 2019 looking at this. And I think one of the issues is that the evidence or the guidelines for statins keeps on changing. And again, particularly for primary prevention. So in 1987, I think 8% of people over the age of 40 were said to be eligible for statins for primary prevention. And in the last guidelines that were produced, that figure is 61%. So that comes close to sort of the medicalization of statins and putting everybody on a pill. And I think some of us feel a bit uncomfortable about this. The side effects of statins are obviously often mentioned, particularly myalgia, I think. I quite like this new concept of nocebo, this sort of opposite to placebo now, where people think they're going to get muscle pain because they've been given a statin and they know that's what they should. And I think that's something that we need to increasingly challenge. The numbers needed to treat the NNT, and I know you'll be familiar with that concept, I think in the good old days was 40, which is probably relevant. This is again for primary prevention. But under the current guidelines, the 2016 guidelines, that's up to 400 patients needed to be treated for 5 years to prevent an event. And that's actually quite a big number. The trouble is statins are quite cheap. From a population perspective, that makes sense. But individually, that's hard. That's sometimes a harder decision to make. And I think the key to this is to make sure that when we do see our patients and we do look at their Q-risk score, we help patients to make informed choices. And they may well be to go on medication, they may well to be on lifestyle changes. But I think if we're going to do that, we need to think about focusing on the highest risk patients first. So the people who've got Q-risk of over 20% and even higher. And I think probably secondary prevention is probably the area where in general practice in primary care, we really need to start to make our efforts in the first place. So what's happening locally and nationally? Well, there's quite a few things happening. There's a bit of a buzz about lipids now. So let me just share with you a few things that are going on nationally and also locally. So in nationally, we've got something called the Accelerated Access Collaborative. This is a scheme which is designed to get some newer drugs and newer treatments rapidly to being widespread use within primary care. There's now a national lipid management and FH program, and both these two national things are being coordinated by what's called the academic health science networks, which are science networks. There's 15 of these around the country. We have an excellent one in our area, which is the Innovation Agency, and they've taken an active lead in lipids now, and they've been very good at helping sponsor some of these webinars. We've also got the CVD Prevent audit that you might have heard me mention before. This is a national audit that's going to come in the spring, which will give us real-time data about where we are with lipids, because we've not been very good at getting lipid information, and it's now out of QOF. Cholesterol measurement is now out of QOF, so we don't really know exactly where we're up to with that. And there's also going to be a new primary care network, DES, also in the springtime, which will hopefully give us more input about CVD prevention and lipids. And the other thing, national initiative I want to talk about is UCL Partners, and they are another example of an academic health science network based in London, and they've come up with a new long-term approach to long-term management, including lipids, and I'll mention that in a minute. So this is the academic health science network. As I say, there's 15 of them. They're looking at the accelerated access, particularly the PCSK9 inhibitors, which Scott's going to talk about, but also trying to get people to be more exposed to the use of high-density statins. And they've launched their program to try and do this. There's a couple of things that they've done. They're looking at obviously healthcare checks to try and improve primary prevention or to use that. And I think healthcare checks are going to be rebooted and restarted in the new year. Secondary care preventions and FH. I'm not going through the detail of this slide or the next one, but this is just an example of the guideline that they have produced. Now this guideline is out for widespread consultation. It has been approved by NICE and the NHS, but this is quite rightly going to the Pan Merseyside area prescribing committee for them to look at it. But then this is a good guideline, I think, for you to be looking at, and it basically focuses on the use of the atorvastatin in primary and secondary care at differing doses. They've also come up with I think a good pathway on statins, and this is all intolerance, and this also is going to the ABC for their comments and their support. And this is quite a good way of trying to work out how best to treat people who are complaining about aches and pains with statins and some potentially more serious side effects, although these are quite rare. So these are just for reference, and the slides will be included, but I think these are quite good pathways. CVD Prevent, we've talked about, and as I say, this is going to come up nationally, and we'll know a bit more where we are in terms of lipids. UCL Partners, this is the Academic Health Science Network in London, and they've come up with this a new scheme whereby you can triage your records, identify your high-risk patients, and hopefully monitor them. And they've got good programs for diabetes, for asthma, for hypertension, and they're developing one for lipids. And they're a website worth looking at. Locally, and I know I'm coming close to time, just to mention again, our Academic Health Science Network, as I said, the Innovation Agency, they are pushing hard on lipids now. They're looking to appoint someone from primary care to help with their work, and that's an advert if you want to get involved with them. They're doing some quality initiative work in Formby and Sefton. They're very keen on the FH service, and we're developing a business case to try and get a better Cheshire Merseyside FH service. And again, the initial focus, I think, is going to be on secondary prevention. Happy Hearts is a website that you should always have a look at. This is a local site with lots of information about all the three things: blood pressure, AF, and cholesterol, and that's worth a good look at. So my final slide, a summary slide. Lipid management has been, I think, neglected as part of the recent CVD prevention. I think there's a lack of a credibly resourced FH service. Statins as cost-effective and safe, I think, are well established, especially in secondary prevention. And I think we've got newer drugs and therapeutic options now, which we should consider for high-risk patients, and watch this space, because lipids is actually going to be probably the next year post-COVID. There'll be a lot of interest and push for it. So thank you very much. And I hope that's just an overview of where we are at the moment.
Thank you, Bruce. That was a whistle-stop tour, wasn't it? So
It was.
that was great. Please do use the Q&A function. I've got some questions of my own. I'm sure others will have questions too. We'll come to those after the other two presentations, but that was great and really good to set the scene.
Thank you.
So we're going to move straight on now, though, to Suzanne. Secondary prevention of CVD. Over to you, Suzanne. You might need to unmute.
That would help, wouldn't it? Sorry, Jonathan. Can people see my slides?
Yes, we can.
Okay. And sorry, Jonathan, can you actually see me? Because I'm having just a few problems with the Zoom.
We can't see you, but we can see your slides at the moment.
Okay, right. That's probably a good thing. Okay, so I'll crack on to make up some of the time. So I'm very much going to build on from what Bruce has started there. I am going to focus on the secondary prevention element, but I think a lot of what I'll share is also relevant to when you're supporting patients around primary care. So what I'm going to cover is some of the evidence for statins. I'm going to just go over very briefly the NICE guidance around the lipid modification, practical considerations to support the prescribing of statins, ezetimibe, and when you think about seeking advice or referring on to secondary care. So I could have just left the slide as there's lots of evidence for statins because there's tons out there, and personally I always used to find it quite overwhelming. So I thought one of the key things to share was the collaboration work, and this is you'll often see this referenced in a lot of guidance, including the NICE guidance. And as it says here, it was a collaboration piece of work where they have looked over a number of significant statin trials to sufficiently power the outcomes that they've come to. And as it says there on the second bullet point, it's 30, they've looked at 30 major statin trials, and we're talking about 175,000 participants. So it's got significant weighting behind it. The key thing for me, I think, when I'm seeing patients is, I suppose I just want a few key messages in my head that I can get over to the patient. So the summary of what they found is, and I know Bruce mentioned this, is for us to all understand and be clear to patients that if we reduce somebody's LDL by 1 millimole, then we are reducing their risk by a fifth, which is obviously a significant reduction. I think the other thing to pick up and explain to patients is if there's then further reductions in LDL cholesterol and with more intensive statin therapy, which is obviously very important around secondary prevention, then again, we reduce further vascular events. Importantly, and I think this is, I used to get a lot of patients asking questions, is that there's no effect on the incidence or of death of any type of cancer, and they are effective across a wide range of patients. I think something I would just add here is when we're talking to patients, I used to get patients that used to get confused because we would talk about them being on a drug to lower their cholesterol, but it's also about them understanding that it's a tool to reduce their overall risk, which again is really important when we're talking to secondary prevention patients because their risk is so high. Okay, so the NICE guidance, it sounds very simple, doesn't it? So it says everybody with CVD, we need to start them on atorvastatin 80 milligrams. It also advises us to consider potential drug interactions, risk of adverse effects, and patient preference. So I used to be thinking about potential drug interactions. We've all got great systems in primary care that will prompt us, but we're thinking of other drugs that are metabolized by the liver. And when we're thinking about adverse effects, we're thinking about the age of the patient. And what has been shown is if people have got a previous history of muscle side effects, then they are probably more likely to have problems. So this is the sort of thing we're thinking about. Patient preference, I will touch on the next slide, is absolutely key. I've just added in at this point as well, it's important to consider and remember when we're dealing with patients, females of childbearing age, that we give them the appropriate guidance. Okay, so this to me is the key moving forward. This is what I used to spend the majority of my time on, making sure that it was an informed discussion, an informed decision by the patient. Patients often present with ideas around statins. They've read stuff in the press, etc., spoken to friends, whoever, and they come in with a preconceived idea. So I think it's really important that we put the time in to help them understand and also take on board what their perspective of risk is. It varies greatly between patients, and it's important we give them the time to talk that through. We'll consider the comorbidities, polypharmacy, and we also need to have a conversation with them around the general frailty and potential life expectancy. I think that's really important. We'll think about lifestyle modifications and discuss those through. So before we start the statin treatment, we need to do the baseline blood tests and clinical assessment. And at this point, when I've considered their risk of adverse effects, that's when would I be deciding if I'm going to do a baseline creatinine kinase, if I think there might be a problem. I treat any secondary causes of dyslipidemia. So if we pick up there was underactive thyroid, we'd deal with that. But most important, we would not delay statin treatment in secondary prevention to manage the modifiable risk factors. That's not saying they're really important, and we'd be talking to our patient. And what I used to find was very useful was to go through their cholesterol results in a bit more detail. Say, for example, they've got raised triglycerides, and link that into a conversation about reducing alcohol, or maybe a patient that's presenting with low HDL and linking that into maybe they could increase their level of activity and explaining to them the benefits that would have. I also used to find for some patients, it was a lot to take in. So for some patients, what I found would work was that I would offer them a follow-up call that they could go and discuss it with relatives, have a think about what we'd discussed. I would signpost them to NHS websites. The Healthy Heart website that Bruce mentioned has got the nice decision aid on there, and just give them time. I would also lay the foundation that this if it didn't work, there was other options. So if they got the dreaded side effects that's what they were concerned about, we would have other options to consider. I just thought I'd share as a reminder some of the secondary causes of dyslipidemia as far as common medicines, but also comorbidities. And again, this was often just to help patients explain if they had raised cholesterol or particular elements of their cholesterol were out of kilter. So the follow-up is absolutely key, and the guidance is quite clear that we're aiming for a 40% reduction in non-HDL cholesterol. If we don't achieve that, what do we do? So we need to consider their adherence and the timing. I got caught out a number of times with, for example, people that were shift workers, and so it was quite hard for them to, one, their eating patterns were all over the place, but also the timing of their dose was quite a challenge. We revisit how they're finding their lifestyle changes. And if they were started on a dose less than 80 milligrams, then we might increase them up. I fully appreciate this is very labour intensive, but the annual reviews for these patients are really important because it gives us that chance to revisit everything with them. I used to find that patients fed back that a blood test did help them with their concordance, because we're asking patients to take a tablet every day, probably for the rest of their life, and they don't feel any different for it. If they can see a result in their cholesterol dropping, it helps them. We then have to go back to the basics again and think, is there any new secondary causes of increased lipids? That could be new prescribing, menopause, and that prescribing might be by the hospital. So we need to be quite diligent when checking what's going on for the patient, and we need to recheck around interactions. So the adverse effects, I think, is massive, and it is what patients worry about. So liver function, again, the guidance is quite clear. I did used to see patients being stopped sometimes with just a slight increase in liver function. It is quite clear that we shouldn't do that. Muscle symptoms, obviously we need to warn patients. I used to be really honest with them and say, no doubt you'll have heard of this, but please think of other things, like if you've done the gardening, maybe that's the cause of your muscle symptoms, but they do need to come and see us. And again, I think Bruce's flow chart that he showed before that's going through consultation at the moment will be really helpful for people. It's important that we don't just measure CK on people that are asymptomatic, but if there are problems, we do, and then we consider what to do. So if it's over 5 times the normal limit, then we need to stop the statin. If it's less, you can continue, but it's very much a conversation with the patient around how tolerable the symptoms are.
Coming up to 10 minutes there, Suzanne.
Okay, thank you. So what I've shared here is a summary of what we would do around managing patients if they're having adverse effects. And it's important, certainly if there's been deranged results, that we continue to monitor them to inform us. It might be that we consider other options or advice from secondary care. This is just something I'll quickly share. I used to regularly use this in my clinics because it helps me understand what the other options are. So around concordance, the timing of the doses of the drugs, what percentage of reduction in LDL I can expect, but also the pharmacokinetics. So just very briefly, the lipophilic drugs are more likely to be taking up into the muscle. So if there's muscle problems, that's more likely to be caused by a lipophilic drug. Ezetimibe, I'll just cover this really briefly. Obviously, this is another option within NICE guidance. I think my key message for anybody is you need to monitor the response. And I used to say that to patients because it's blocking the absorption. Some patients are high absorbers or low absorbers of cholesterol from their diet. So their response can be massively different. Advice from secondary care. So I think it's really important for certainly secondary prevention patients, when we're struggling to control, the statins aren't an option, then it's time to seek advice from secondary care. Thank you.
Thank you very much, Suzanne. So that's great. Just to reiterate, we do have the Q&A box, so people are asking questions, which is fantastic, but please do put in your questions in there. We've already had one question about whether this recording will be sent out, and yes, all delegates will receive this recording, so please be assured of that. Thank you, Suzanne, for that. That was great. We will move on to Scott. So you're going to talk to us about lipid optimization, new and emerging therapies. Over to you.
Thanks a lot, Jonathan. Can everybody see these slides? Yeah.
We can, thank you.
Great, okay, so it's my job just to try and unfortunately make things a little bit more complex. I know we're aiming for simplification for patients, and I think that should continue, but you guys as healthcare providers need to know a bit more detail about where we're up to with cholesterol and some of the thinking that's going on in 2020. Just a brief history lesson. In 2004, when Salim Yusuf completed the InterHeart study, he published this paper showing that the 9 modifiable risk factors for myocardial infarction included abnormal lipids. Now, we would probably say total cholesterol, LDL cholesterol, bad cholesterol, whatever you want to call it, to patients. But in actual fact, even though there was 80 to 90% preventability of heart disease in this trial, the risk factor that was measured that had the highest population attributable risk was a lipid marker in this study, but it wasn't total cholesterol, it wasn't LDL cholesterol, it was the measurement of ApoB, apolipoprotein B, or all your bad apolipoproteins, divided by ApoA1, which is all of your good apolipoproteins. So you have to remember that cholesterol, it's the same cholesterol that's in low density lipoproteins as is in high density lipoproteins. That's all the same, it's just contained within different lipoproteins. So I know we put that over to the patients extremely simply as good and bad cholesterol, but as healthcare providers, you need to know that there are further facets to this. And why was ApoB over ApoA1 so predictive? It was a linear relationship. The higher that this goes, the higher your total bad lipoproteins over your good one goes, the amount of cases increased up to odds ratios of greater than 4. And current thinking starts to suggest that the reason why people's lipids, and particularly their ApoB or their bad lipoproteins seen here, and you can see here their good lipoproteins or HDL are rising, is because the body metabolically is not doing its job. So this is aside from FH or any other genetic causes for raised cholesterol. This is what can happen as the body's homeostasis and normal physiological processes don't work properly. And if you're overfilling your adipocytes and becoming more and more resistant to insulin, then you are likely to see a change in the way that you manufacture cholesterol lipoproteins in your liver. And you can see the difference here between men and women. If you are completely insulin sensitive, there's a total difference in many cardiovascular risk factors compared with if you have insulin resistance. And if you look at this total here between insulin sensitive and insulin resistant patients, you see there's a big difference in the lipid markers. So why have we moved from LDL to total over HDL or non-HDL cholesterol? And it's because that's a better measure of total ApoB. LDL does go up with ApoB and they tend to be concordant, but there are cases where there's complete discordance between LDL and total ApoB. So that's why the total over HDL ratio or non-HDL cholesterol is very useful. And that actually increases, just as increasing ApoB over ApoA1 ratio increases, that is showing how insulin resistant the person is. And it's the basis of the insulin resistance and hyperinsulinemia that's creating the cholesterol abnormalities in a lot of patients. Just to show you a bit sort of more technical on this, sorry, jump back. It depends on the triglyceride pool in your liver, or the total triglycerides the liver's having to handle, about how you make your cholesterol and how you ultimately the liver creates ApoB100 or apolipoB lipoproteins. Triglyceride is so important here, because if you have lots of triglyceride trying to be managed, you will make this type of LDL cholesterol. You will make small, dense LDL cholesterol, and it will be more readily oxidized, and it will hang around for longer. It won't be picked up as well by the liver or reused. And that's why statins are very useful, in that they will potentially lower your oxidized LDL cholesterol in the system. But it is still possible to have a low plasma triglyceride and to make a different form of LDL. So a bigger type A pattern LDL that's bigger and more buoyant and less likely to be oxidized. And actually you see in this case that this person's ApoB is low compared to this person here, where their ApoB is very high. And the hope is that by just understanding this a bit more, the importance of triglycerides, the importance of HDL, just to confirm what type of rise we've got here in cholesterol. And we know from a paper in JAMA recently that men who had high triglycerides and a low HDL had significantly greater risk of heart disease, even when the LDL was high or the LDL was low. And the reason for that is the signal that they have atherogenic dyslipidemia. So I would compel everyone to get a bigger lipid profile where possible, and not just to focus on total cholesterol, to focus on whether the triglyceride to HDL ratio is greater than 1.5, because that signals really increased risk, and possibly that there is diabetic physiology at work. So here is where the action happens. The modified oxidized LDL gets stuck in the wall of the artery and creates this pro-inflammatory process. So there are outstanding questions that need to be answered in terms of new medicines that are coming through. So can we use PCSK9s? We've already started using these in order to regenerate the LDL receptor and pick up more LDL from the system and regenerate it. The problem is that if your LDL is oxidized, occasionally the LDL receptor doesn't recognize that, but it is one of the new tools in our armament. There are newer therapies coming through all the time, and I'll touch on that in a second. What I want to stress to people, though, is that we tend to see people at this point, symptomatic release, revascularization, secondary prevention, and the job as us as preventative champions is to push this back down here to where education, lifestyle interventions can be used, and then obviously control of traditional risk factors way beyond the time before symptoms start. And where we need to be targeting is the fact that many people are starting way back here in their teens and 20s, where their adipose tissue surrounding their heart arteries and surrounding their heart is becoming inflamed. So the same as fatty liver, this is also happening to the heart, and it's causing inflammation to upset both inside the vessel wall and outside the vessel wall, and affecting the signaling here. That is then obviously moving on to where LDL gets trapped and can't get out, and then the inflammatory reaction starts. So obviously acting back here to promote healthy lifestyles to make sure people aren't over fat or having fatty liver or fatty heart is where we should be moving the needle to. Obviously, there are,
Scott.
Yeah, sure. There are lots of drug treatments for dyslipidemias. And at the moment, we're starting to see evidence come through for a drug called bempedoic acid, which acts earlier on in the chain from statins. It's a citrase lyase inhibitor. And basically that will reduce your cholesterol production and allow you to regenerate your LDL receptor better. There's evidence coming through for some of the omega-3 fatty acids, long chain fatty acids, so giving fat to the body to change the way the body handles their production of cholesterol from the liver. And there's a few recent trials, one called Reduce It, looking at icosapentaenol ethyl, or a very strong form of EPA, 4 grams, which has shown good results, almost statin-like results. But there's been another trial recently, the Strength trial, showing that if you combine EPA and DHA fish oils together, that you don't get the same results. So it may be in the future that we'll be prescribing high-dose EPA to patients with statin-like results. We're already using PCSK9 inhibitors, and I think one of the things we need to look at is the pathway for that, and how and when it should be used in what particular areas. The strongest evidence appears to be in people after acute coronary syndrome. So that is something that may be built into the pathways going forward. Bile acids, nicotinic acids, and fibrates are kind of off the agenda now. It's not something that we use because of the new therapies. But I'd like to put it to you that these are just plasters, and that the main thing we should be focusing on is the health of the liver. So, you know, don't overload your liver with sugar and alcohol and too much energy, because it will struggle to process the extra triglyceride. Don't overfill your adipocytes, because if there's no room at the fat cell motel, those non-esterified fatty acids will have to go back to the liver to be repackaged. So getting patients to realize that if they lose weight, they cut their sugar and alcohol intake, that will have an effect. And to finish up, these are the things that are on the horizon in terms of lipid management. There's a large trial called Orion-4, looking at a drug called inclisiran, which is a small RNA interfering drug which basically blocks the synthesis of PCSK9 for a longer period. So doesn't need injections as often as PCSK9 inhibitors. There's bempedoic acid, as I've discussed, which reduces cholesterol synthesis, and we're waiting on the outcome trial for that called CLEAR Outcomes. And there are 2 further planned studies looking at ApoA1 mimics, human mimics of ApoA1 to increase cholesterol efflux, and drugs to target lipoprotein A, which is another sort of complex factor involved in cholesterol management and heart disease. So how do you recognize someone who's insulin resistant? Their waist to height ratio. How do you prevent that? You get them to eat decent food that's nutrient dense, avoid the glycemic impact of sugars and alcohols, high intensity exercise where possible. So I'll spin through this, but this is just basically to say that many patients are dysglycemic. They may not be diabetic, but if you look at this study from the UK Biobank released this year with 440,000 patients in it, if their total cholesterol rose by 1 millimole, there was absolutely no difference in outcome for cardiovascular disease. That's total cholesterol. But if you look at they were diabetic, or if their HbA1c was rising, it goes up to a hazard ratio of up to 4. So I think that although we focus on lipids, a lot of the lipid abnormalities are actually coming from diabetic physiology, and that can be attacked by knowing how much time you spend in range and using newer devices to find out how to lower your overall time in range and to stay within normal glycemic limits, and obviously to use exercise to reduce insulin resistance and arthrogenic dyslipidemia. So I'm sorry, I'll finish up now. I'm sorry that it was a bit more complicated than you maybe expected, but it's just to lay down the line that there are other options, and I think drugs will always come through from big companies, but it's our job to make sure that the patients understand what they can do in combination with the drugs to improve things greatly. So thanks for listening.
Scott, thank you so much. There was a lot in there, wasn't there, for us to take on board? So just to reiterate,
sorry.
No, don't apologise. And just to reiterate to everybody that the slides and the recording is going to be pushed out to everybody, all delegates. So you can go back through that because there's a lot of information, and I think it's really helpful for us to have that when we're having our conversations with our patients. I've got some questions, and actually, Scott, can we stay with you for the moment, because I think that last bit that you were talking about was what I was thinking about throughout this presentation, and you talked a lot about insulin resistance. And the question that I've got was, is the answer more and more drugs? We've talked about statins a lot, but if it's all about insulin resistance, is it a different approach that's required?
Yes, that's what I've been campaigning for the last 5 years, because I think that it's difficult to activate patients, but there are some, very simple messages that very occasionally you just see them suddenly think, oh, right, I didn't know that. So I've had patients come to my clinic with cholesterols of 11 and triglycerides of 39. And I just say to them, what in the name of the little man are you eating? And very many, a lot of them will say things like, well, I have 4 muffins for breakfast and I have a Chinese meal every night because I can't cook for myself. And then suddenly you start saying, well, don't do that. And this one chap came back and his cholesterol was back to normal just by cutting out the muffins and the Chinese meals. But in any other situation, he would have been slapped with a statin, which I agree. I still agree that it should be done. Statins should not be delayed. I agree with that. But we shouldn't be placing a sticking plaster on what is a metabolic disorder in many patients. That's the basic tenet.
Yeah, so similar question. So there's a lot of stuff about diabetes at the moment and about very low calorie diets and low carbohydrate diets, showing that you, particularly people who are recently onset of diabetes, and you can reverse that. Is there similar evidence that you can manage your lipids by these very dramatic diets in some cases?
Yes, because I mean, the reason why triglyceride will be high, and you'll be packaging a huge amount of VLDL out of your liver, which will ultimately, as triglyceride is dropped off for energy requirements, will end up being LDL cholesterol. And the fact that LDL cholesterol is the longest residence time means that's why it's the bad cholesterol. But if you can cut the amount of triglyceride that's either coming in the top end or stop it from spilling out of your adipocytes, i.e. empty your adipocytes and don't give them as much energy, eating 4 or 5 times a day, then that's why very low energy diets and very low carbohydrate diets work, because you're basically allowing the system to sort of clear out all the extra energy that's there, blocking up the pathways.
Thank you. Suzanne, you wanted to come in?
Yeah, I was just really going to echo what Scott said then, because probably as a pharmacist, when I started seeing patients, I thought I would be signing lots of prescriptions for statins, whereas over the years, I've probably had the biggest impact with getting patients to change their lifestyle and then not needing a statin. And I think that's really worth people taking on board.
Thank you. But while you're speaking, Suzanne, we have got some questions about statins, because that is what we've been prescribing for our patients, and so we need to be clear what we're doing with regard to those. So the question came in about statin doses and whether that should be age related. So should we be adjusting statin doses based on age alone? I
used to very much go on a conversation with the patient, because I think that, I think the thing there was about an 80-year-old, there's 80-year-olds and there's 80-year-olds, isn't there? So it needs to be patient specific, where you discuss it with the patient and you come to a joint decision on it. I don't think you can say a blanket purely on age. You have to obviously acknowledge there might be an increased risk, side effect risks, but that's part of your discussion. I don't know if the other clinicians would agree with me on that, but that was certainly my approach, individual patient approach on it.
And that, I guess, I had a question about, so we've got our looking at care home residents and medicines optimization in care homes, and how I guess you answered that question there, don't you? So how do you approach people who are approaching end of life and you're trying to rationalize their medicines, and a lot of them will be on statins and maybe have been on statins for a number of years because they've got underlying heart disease. How should we approach that?
So my personal view, I'm happy for Bruce or Scott to come in, is that, I suppose it's like frailty prescribing. You're looking at what's preventing and what's actually making a difference at that point, I suppose, depending on what part of frailty and near end of life that patient is. Certainly I know within myself and my team, depending on that, we may well recommend for the statin to be stopped because we would question, but I think it's an individual patient, and certainly for patients in care homes, you need to consider discussing that with family members as well, certainly if there's capacity issues.
Yeah, I used to stop statins. One common things I used to stop, really. I mean, I think the evidence in extreme life, it is hard though. You've had someone who's had recurrent mini strokes or big strokes and stuff, trying to do that. But I used to stop statins quite a lot. Just one thing, coming back to Scott's things, because he was giving a very cheery Christmas message there, just coming up to, we can't eat sugar and we can't eat alcohol, so that's going to go down really well. But
no, I mean, it's over the lifetime, Bruce. I know.
I'm going to have to take my Christmas tree down, but he's absolutely right, of course. And I think it's true that COVID, I mean, coming back to COVID a bit, I think a third of people in COVID have actually gained weight or something like that. I read that somewhere. So, and yet in a way, one of the strange things about COVID, the few good things I think about COVID, is that there has been people are realizing for themselves to take more care of themselves in terms of their physical health and so there may just be a slight shift in people taking on more responsibility for their lifestyle as a result of COVID, and I think we need to sort of capitalize on that and sort of make sure we can enhance that going forward. Because I agree with what everyone said, that statins and other drugs are very useful, but we've almost missed the boat when we're giving people statins. we need to be trying to do stuff early doors. With the one exception, I think, of people who are unlucky enough genetically to have FH, and those people, I think we need to really go out and get on the best treatment we can, because you can't dart your way out of FH. I mean, that's just one of the things you've got.
But one of the things I would say about FH is that the Montreal FH risk score, which was created, if anyone wants to look it up, the reason why people with FH will ultimately have a heart attack at a younger age is not always down to the level of their LDL cholesterol. It's down to the fact that they smoke. They've got other genetic risk factors for blood coagulation. Their HDL's low, their triglycerides are high. They don't take regular exercise. So there is another score looking at the risk in FH, and there are, you know, we know now because of computerized tomography and CT scans of the heart arteries that there are quite a few FH people kicking about who've got no coronary artery disease. So black swans exist. And why does that happen? I find that very intriguing. I think there are other elements to FH that are as yet unexplored, but certainly those patients need even more.
I don't know if it's going to come to pass, but it's certainly been muted that they're going to start doing screening of all children. Like you have a heel prick, but they'll be doing that sort of thing. What happens then when you identify FH in a toddler? Do you give them statins? I mean, that's a more difficult question, really. But I think Scott's point is right. We've got to get better at identifying people and actively managing all their risk factors aggressively, because I think that will make a big difference.
Thank you. And so while we're on statins still, so when I prescribe statins, I've been taught make sure it's a nocturnal dose. So maybe Suzanne, why is that so important? Why do I need to tell my patients to take it at night?
So you do for some statins, but not all the statins actually. But I suppose as a pharmacist, we do notice that the doctors have got that into their head that all statins are it. So for example, my thing there around shift workers, that used to be one of the reasons where like rosuvastatin or atorvastatin that can be taken any time of the day is actually quite useful. So the other statins, it's to do with their mechanism and the timing. And if Scott wants to correct me, it's around your peak time of your lipid production as well around the evening. So it's often to do with the half-life of the drug and how long it's in your system for.
Okay. Anything to add to that, Scott?
When you're asleep at night, you're basically, your liver is basically, working overtime as you're asleep, trying to sort out all the mess you gave it during the day. And I think that's where why statins were classically given at night to peak onset of action whilst your liver was going through the valinate pathway. It's interesting because this new drug bempedoic acid obviously acts a bit higher up the chain than statins do. But looking through the initial data for that drug, one of the things that it does is it increases your uric acid production as well. So you have to remember that whenever you drop a drug into a tightly controlled physiological system that was made for whatever reason to produce cholesterol for the body because it's needed, you have an equal and opposite reaction in other elements of pathways that we don't understand. So an 18% increase in gout or uric acid production in some of those bempedoic acid trials. So I think we just need to be careful that we don't interfere with Mother Nature too much when what we should be doing is telling people to eat and live like how we should be, not endlessly storing up for a winter that's never coming.
Okay. Well, we are going to finish at past. I think there's time for another question. I was wondering, Scott, I'm not sure we can do this, but should we be measuring ApoB, ApoA1 in primary care? Do we need to teach ourselves to do that and to understand how to interpret it?
I think the non-HDL thing is actually as close a proxy. I think the reason why I showed those slides was just to make the point that was the best lipid marker of risk. And I think that, we know that some people have completely discordant total ApoB and total particle count. So that also matters compared to the calculated LDL cholesterol that you get in the lab when they mash it all up and the Friedewald and different ways of actually calculating LDL. So I think we get around it by measuring non-HDL cholesterol reasonably well. It would be better if we moved forward in primary care to somehow being able to get an idea of whether someone is over fat for their body type. And in the future, hopefully we can measure something called adiponectin, because you don't know whether you're over fat or not. You don't know what your maximum fat cell capacity is. There are people who come to my clinic who are 30 stone and they don't have fatty liver or diabetes. Yet there are people who come who are 9 stone and they're absolutely ravaged with diabetes and fatty liver. And it all hinges on how well you can store fat. And if your adiponectin's low, it means that you're obese for you. And I think that we'll move on in the future to do more insulin metrics, adiponectin, metabolic type work in order to work out what the patient's doing wrong. But ultimately, it boils down to diet and exercise.
Yeah. Okay. Thank you all so much. I am going to sort of wrap things up because it's very nearly past. Just to say that if you're wanting any more information about any of this, we were going to plug the Happy Heart website, and that is available on the HCP part of the site, but it's being restructured at the moment. It's to make it more useful for healthcare professionals. So I think watch this space with regard to that. If any of you want more information about any of the EMIS or TPP search tools that are available to look at lipids optimization, current care, QI around that, then we can put details in the email going out to participants about that, so you can get back in touch with the Innovation Agency. So there is more information and resources out there. You can obviously go back over these slides as well. Huge thanks to the Innovation Agency who have helped put this series together. So certainly for today, Michelle, Philip and Alison, I know other participants can't see you there, but you've been part of the team, and thank you so much for coordinating and helping us with this. But of course, thanks to Suzanne, to Bruce, to Scott for your slides today, your presentations, really interesting, lots of food for thought. And of course, thank you to everyone that's tuned in, because without you, we wouldn't be doing this at all. So thank you for your keenness and your passion to make sure that we are managing patients as best we can through this, as we heard before, leading cause of death still. Thank you for taking your time out of your very busy days. Lots of other stuff going on. I will mention the COVID word again because it is what is keeping us all occupied at the moment. But we're really grateful that you've taken this time today to join us. Thank you all so much, and please watch out for your emails coming out to you. Thank you all, and goodbye.